Good afternoon and welcome to Is a Total Knee Replacement Right for Me? My name is Michelle Rosales and I am a clinical nurse educator here at Hospital for Special Surgery. In this webinar, we are going to talk about whether or not a knee replacement is the right decision for you and your health by breaking down what a knee replacement is, the overall procedure, the recovery, and the newest advances in care. Our guests today are Dr. Brian Chalmers, an orthopedic surgeon here at HSS, and Matthew Pugliese, a physical therapist here. Glad to have you both here, and thank you for joining us today.
Thank you for having us.
Thank you.
Great. We are going to discuss the trajectory of what a total knee replacement entails for patients, including when you should seek a knee replacement, some of the post-operative considerations, and how technology has assisted in this successful procedure. But before we get started, if each one of our guests can introduce themselves and what exactly your role here is at HSS. Dr. Chalmers, if you could please start us off.
Sure. Thank you for having me. It's a great event to put on by everyone here. I'm Brian Chalmers. I'm one of the hip and knee surgeons here at the Hospital for Special Surgery, which means I essentially only do hip and knee replacements, and that's what I specialize and focus in. So I do about 300 total knee replacements a year, and happy to share kind of my thoughts and what experiences of our patients here with everyone today.
Great, thank you. And Matthew?
Yes, I'm Matt Pugliese. I'm a physical therapist at the Westchester Outpatient Center. And we see a wide variety of diagnoses, from knee replacements to hip replacements to even ankle replacements, and a whole other host of musculoskeletal diagnoses. And just excited to share kind of the recovery and the rehab perspective on total knee replacements.
Fantastic. Okay, so to begin simply, what is a total knee replacement? Help us to understand the knee and its structure, Dr. Chalmers.
Yeah, so I think it's a common misconception of what a knee replacement actually is. So we're going to model here. I have a model of what one looks like. It's probably best to portray it. So essentially, this is your femur bone. This is your tibia bone. And we essentially just remove a small amount of bone from that and resurface the knee with a metal and plastic implant. So there's usually a metal part on the top and a metal part on the bottom and a plastic insert between it. So it replaces that bone-on-bone arthritis. So really is actually a minimal removal of bone and really just removing the cartilage from the knee. So it is a metal and plastic implant. That's commonly asked about what it is. And so that's the overall goal, is getting rid of that arthritis type of pain that patients have.
Okay, great. And who may be a candidate for knee replacement surgery? How do I know if I need one?
Yeah, so the best patients that are candidates for them, it's really dependent on a lot of different factors. One, how well they're doing with their pain and function and quality of life, what the X-rays look like, kind of what their goals are with their function and quality of life. Really, the vast majority of our patients that we see have, severe arthritis on X-ray, which means, they've completely worn away the cartilage over time. Arthritis, is a little bit of a catch-all term that we often use, but really, in its simplest definition, is wearing away of the cartilage on the knee or the hip or other parts of the body, specifically the knee, over time. And that wearing of the cartilage can lead to it being bone on bone. And that bone on bone, every time you walk or bend or straighten the knee, can be painful. That bone on bone also creates a lot of inflammation in the joint, which can cause swelling, soreness, pain, and it can also cause some destruction of the joint and erosion of the bone and bone spurs. So the vast majority of patients we treat have, severe arthritis that have developed over time. How that typically manifests is that patients typically have pain, usually with weight bearing and exercises like stairs and walking, and other, biking or hiking or other activities that they want to do. And also oftentimes pain at night. Typically for treatment, most of the patients that we see have already started some of the treatment on their own or with their own primary care doctors, such as physical therapy to strengthen the knee and to try to keep the range of motion, medications like Tylenol, anti-inflammatory medications like Aleve, Advil, ibuprofen, those types of things. Obviously modifying your activities and not doing things that hurt, like kind of avoiding stairs, avoiding the bike, and avoiding those types of things. Some patients, when it gets very severe, need to start using a cane or a crutch or another gait aid because it really hurts to walk and they're, very, very immobile. Another option for treatment of the arthritis in the knee is injections of steroid or gel type injections. So typically most of our patients and many patients we see have already tried all of those things, and it hasn't provided them the long-lasting relief and quality of life that they want. And so most, a good candidate for knee replacement or who would benefit from a knee replacement is someone who has severe arthritis, has tried most of those things that I just discussed, and has pain that limits their function and quality of life and really doesn't allow them to do the things on a day-to-day basis or a week-to-week basis that they want to do.
Okay, great. Now, are there any steps that someone can take to avoid a surgical intervention if they're a little afraid of moving forward?
Yeah, so there are steps you can take. Unfortunately, we don't have anything as far as a pill or procedure or anything like that that can regrow or regenerate cartilage now. There is a lot of talk about stem cells and PRP, and there are some studies and experimental things going on with those to see if that can regrow or regenerate cartilage without needing additional surgery. Unfortunately, those are not shown in arthritis, especially severe arthritis, to regrow healthy cartilage in patients. But maybe in the future with better technology that may be an option. So there's really no way to regrow the cartilage. And so the best things that you can do to try to prevent the arthritis from worsening over time, or just to make your knee feel better so that you don't, end up needing to have the surgery, are keeping the muscles strong in the leg. The more forces that go through the knee, the more that it's going to hurt. And so the stronger your muscles are, the less forces that your knee sees. So whether it's formal physical therapy with our colleagues like Matt and his colleagues at Westchester, exercises on your own, I always encourage low impact exercises over higher impact things. Those would include, walking, hiking, biking, swimming, elliptical trainer, avoiding repetitive high impact things like box jumps and CrossFit and running, are really going to, help prolong the life of your knee. The biggest other thing is patient's weight. The heavier you are, if you have 10 extra pounds on, your knee sees actually about 5 to 7 times that. So keeping your weight down and keeping it in good shape, is really the best way to try to prevent the arthritis from getting worse over time, and typically makes patients' knee feel better even if they have bad arthritis.
Okay, great. Thank you. Now, when it comes to replacing a knee, how does one know what are the options? Do we need a total knee replacement versus a partial knee replacement? What are the key differences between the two?
Yeah, it's a great question and something that I talk to patients about, on a daily basis, really. So there are those two options, essentially a full knee replacement or a partial knee replacement. A partial knee replacement simply means that you don't replace the entire knee. And you really only target the one portion of the knee, whether that's behind the kneecap, whether that's on the inside part of the knee that has the severe arthritis and the bone-on-bone arthritis. The main difference is, the main benefits of a partial knee, if you're a good candidate for it, Some patients, just have arthritis throughout the whole knee and are not a good candidate for a partial knee replacement. But people that are a good candidate, the main benefits are typically a bit easier recovery. So most patients are able to go home the same day. The recovery is not quite half, but probably about that of a knee replacement. Still is, obviously a recovery and got to work hard with exercises and physical therapy afterwards. It's just the pain and swelling and soreness are a little bit easier after a partial knee replacement. The motion is a little easier to get. And also the knee feels a little bit more like a normal knee. We keep all of your ligaments, we keep most of your knee, except just the part that's really, really worn out. The downside of a partial knee replacement is that other parts of your knee can wear out that haven't been replaced. So there's a little bit more likelihood that other parts of the knee could wear out in the first 10 or 15 years. You may need it revised to a full knee replacement if that occurs. So the downside is there's a little bit higher likelihood of needing additional surgery down the line at 8, 10, 15, 20 years if you have a partial knee replacement, whereas a full knee replacement most likely to be the most durable and last for the longest period of time.
Okay, great, thank you. Now we're going to discuss a few questions on the surgical process. So I've heard the term prehab. Is there anything that I can do before surgery to prepare or to make my outcome more successful after surgery? If Matt, you could help us answer that.
Yeah, I think kind of alluding to what Dr. Chalmers said before is really getting the musculature around the knee as strong as possible. And that can include the hip muscles as well. Also, things like working on balance and working on aerobic conditioning are all beneficial, because what we see is preoperative function really can correspond to postoperative function. So getting as strong and as conditioned as best as possible is really, really advisable. The caveat being, if you're doing exercises that increase pain, increase swelling, or increase really irritation in other joints, it might not be beneficial. So exercises that are low impact really are advisable to try to get you prepared for surgery.
Okay, great. We've had a few questions about the type of implants, but what are the implants typically made of? How is the material matched to fit the patient's individual needs? Is this something that we discuss with our medical providers, or how would one know? Dr. Chalmers.
Yeah, so there are basically the vast majority of implants are made out of similar materials. There's really only a few options for the exact material that it's made of. So the femoral part, or the top part of the knee, is either made of cobalt chromium or what's called oxinium, which is a ceramicized metal. There are other, very uncommonly used metals or other types of materials that are used on that side, but that's more than 99% of the knee replacements that are done. It's mostly implant and company specific. The company or implant that your surgeon decides to use can be somewhat specific for the patient, but mostly has to do with the surgeon's comfort level and their track record and how they've seen that implant with those types of patients do over time and their experience with it. So there is some change based on the patient, but a lot of it is the surgeon experience, and that's something obviously patients should discuss if they have specific concerns about the implant. The plastic portion is all very similar across the companies and implants. It's called highly cross-linked polyethylene. The problem with older knee replacements and older designs of knee replacements that we did 20 years ago was that plastic would wear out over time. Now, with modern plastics, and especially that we've been using in the last 15 to 20 years, it's very unlikely that those would wear out. We've been using them, like I said, 15 to 20 years. And at that point on x-ray, we can measure almost no wear. So that has been a major advancement in knee replacement surgery in the last couple of decades. And then finally, the bottom part that's on the tibia part, that is titanium in the vast majority of implant companies, and that very little change in that material that it's used.
Okay, thank you. Now moving forward, we're going to discuss the recovery and the post-operative care. You both can chime in on this. What does the recovery look like for a patient who received a total knee replacement? What can they expect in the rehabilitation process? And how long will it take to recover?
Want me to go?
Yeah, Matt, go ahead.
Please, sorry.
I'll take it from an outpatient perspective. We usually see these patients anywhere from 10 days to 2 weeks, and even later in an outpatient setting. Really initially, the goal is to quiet down the knee, get the knee starting to move, and generally introducing exercises to wake up some of the muscles in the knee and the hip. Everyone really starts at a different spot, and that's based on their preoperative level of function. And so we'll tailor exercises to other regions based on our evaluation and what we see. So in terms of time frame, really at a month, people are usually generally feeling pretty good, and they're walking around quite well, with or without an assistive device, depending on really their preoperative level. But really at 2 months, 3 months, they're really getting back to life and getting back to the things they once were doing before. And then really long term, it depends on the goals and the expectations of the patient, what they want to get back to. And that's really what we tailor exercises and interventions from 3 months on, to really getting people back to maybe doubles tennis or biking, things like that they want to do. So it's hard to answer generally, but everyone's different, and generally people are feeling pretty good at 3 months.
Okay, great.
Yeah, so yeah, I agree that, on the therapy side, that's generally what I tell patients as well. I kind of have a rule of threes, and like Matt said, everyone's different, and some people recover extremely fast. Some people need a bit more time, and that's very normal. But I generally have a guideline of threes. After 3 days, most people are up and walking around their house, and usually using a walker. But we want them up and walking and going to the bathroom and doing most things independently around the house. But really, for the first 2 or 3 weeks, it's a little more limited, and they're kind of, not doing much outside the home, and just starting at the 3 to 4 week mark, kind of turning the corner, getting out of the house more, getting back to driving, starting outpatient therapy, doing, errands on your own, probably on a cane or even weaning a cane at that point. But really takes, 3 months and sometimes even a little bit longer for patients for that swelling and soreness and activity level that they want to be at and feeling confident to get back to. So it does take some time, and that's what I tell every patient that I'm going to operate on. Is the tough part about knee replacement surgery is the recovery, especially for the first few weeks. It's the knee's pretty gets pretty swollen and pretty sore, and it takes a lot of work with therapy and on your own getting the range of motion back.
Okay, thank you. Now, pain. How much pain can a patient expect to be post-operation, and how long does that pain last?
Yeah, so I think everyone has varying levels of pain. Some people can get by with taking very minimal narcotics for a day or two. Some people need them for a few weeks, and it's very individualized. I would say I have a lot of patients come and ask what 4 different types of medications prior to surgery. I'd say the people that have the most pain after surgery are ones that are taking narcotic type medication before surgery, just because it's very hard to control your pain just because you're tolerant of it after the operation. So I would strongly recommend avoiding that, or if you're on them, getting off of them before surgery, because it makes the post-operative recovery pretty tough. But in general, if you're not on narcotic pain medication prior, most people need narcotic pain medication for a few days to a couple of weeks. and and are icing it and kind of just babying the knee, like we had said, for the first few weeks, icing it and getting around with a walker or cane. And but it's definitely sore, and that's kind of the tough part. We do everything we can with pain control around the time of surgery to help with that. We put blocks around the knee with anesthetic and pain medication. We do the surgery with a spinal, so that helps with the pain receptors and decrease the level of pain and nausea after the surgery. I inject pain medication all through around the knee. We give you things through the IV as well as orally. There's 5 different medications that act in different ways to try to help with the pain and swelling and soreness. So it's significantly better than it was 10 years ago when we kept people in the hospital for a week and they were on an IV pump for a week at a time. And so the level of needing narcotics and having just extreme intense pain is low now. But it's not an easy kind of cakewalk to do. And so I always counsel patients appropriately on that.
Okay, great. And Matt, are there any knee-friendly exercises that one can do to help alleviate the pain?
Post-operatively, it really depends, but I would say gentle range of motion generally can help. Actually, getting up and walking and moving generally helps. Usually you'll see the individuals have pain after they've sit for a long period of time or getting out of bed, and as they start moving around, the pain will generally get better. And then icing is really nice for pain post-operatively, and things like that can make it a little more tolerable. But generally, movement is really key in this stage.
Okay, great. And lastly, what is a rapid recovery knee replacement? How does that differ from both a total or a partial knee replacement, Dr. Chalmers?
Yeah, so I think both a total and a partial knee replacement, we essentially do all of our surgeries as a rapid recovery protocol. That essentially means what we talked about before, or what I kind of alluded to before, on everything that we do around the time of surgery to try to make people as comfortable as possible and have the best experience as possible. Like I said, I think that's one of the best things that we've improved on in the last 10 or 15 years is the patient experience, the amount of pain people have after surgery, and how quickly we get them up and walking and doing things. As Matt said, people feel a lot better moving after the surgery. So we definitely don't want people to kind of sit in bed. But the full rapid recovery protocol really begins prior to the surgery. We want people, drinking fluids, and we used to tell people not to eat or drink anything for 24 hours, but then you get dehydrated and need more fluids after surgery. So we tell people to drink fluids. Part of the prehab kind of workout regimen is part of it. We use different medications in the operating room now to help prevent blood loss. So the likelihood of getting a blood transfusion after surgery, which would, delay your rehab and delay your hospital stay, is extremely low now. We do the surgery with a spinal anesthesia, which typically reduces patients' pain after surgery, reduces the amount of narcotics that you need, reduces the amount of other anesthetics that you need that can cause nausea and vomiting and things like that. We do blocks around the knee, which helps with the pain control. So we do several anesthetic medications around the knee to help with the pain control in the early on phases. After surgery, like I talked about, there's a multimodal pain regimen that we do with 5 different medications that all work in different ways to try to help that. Cold therapy and ice, like Matt discussed, very helpful right out of the get-go. And then, we get people moving as soon as possible, getting up and walking around usually the same day, if not the next morning, depending on the time of your surgery. That helps prevent blood clots, it helps prevent getting into pneumonia, it helps prevent a lot of post-operative complications, and also keeps the muscle strong in early kind of rehab. So all of that, protocol and everything we do to try to, make it more of a model of, a healthy patient model going through, and that, we don't want you in bed and on all these high dose medications and having, complications and sedated and nausea and vomiting and all those things, and really, doing everything possible to make as minimal of pain, getting up and walking around as quick as possible, and the experience as best as possible.
Okay, great. Thank you. Now moving into advances at HSS in terms of total knee replacements and what sets us apart from other hospitals. You alluded to technology. How has technological advances contributed to the care a patient may receive here at HSS? If both of you can weigh in. Dr. Chalmers.
Yeah. Yeah, so I think the three things that set us apart, there are probably four things that set us apart from other hospitals and other locations. One is the, rapid recovery protocols that I have talked about that we've, fine-tuned and honed over, the last decade, really. We do, collectively as a group, we do thousands of knee replacements a year. And so we've really fine-tuned this process and, getting really the best care possible by the highest volume people possible. So I think that's, number two is we do more than anyone in the country here. And so, collectively as a group, our anesthesia team, our nursing team, our preoperative team, our surgeons, our physical therapists, really everyone is on board and knows all of the protocols and knows, what's normal, what's abnormal, and really, are very fine-tuned and in tune with what needs to happen in this process. I think secondly, we do use a lot of technological advances in the operating room to help execute the surgery more efficiently and more effectively. We use a lot of technology and computer navigated and robotic devices. We have I think 8 or 9 robots of 3 different companies that we use to help not only make our surgery more precise but more efficient. And I think that helps with not only long-term outcomes for patients, not having the knee wear out or loosen up, and just overall how the knee feels and the balance and feeling a little bit more like a normal knee, but also in the early recovery. So we're kind of innovators in that space, using those types of advanced technologies and trying to improve the outcomes for our patients. And I think lastly, I think one of the things that many of the surgeons here do is help implant companies design things that are better, and we're always moving the envelope forward to try to improve implants so that we can hopefully achieve a more normal feeling knee for patients, a more durable and longevity of the knee replacement, and really ultimately improve their outcomes. So like I said, a number of the surgeons and other physicians and people at HSS, engineers, biomechanics, working on with companies improving our implants and designs and techniques. So I think that's what's unique about HSS and sets us apart from a lot of the other places around the tri-state area.
Great. Is there any work or research that either of you are particularly excited about, or anything else that you'd like to share?
Yeah, so I think on my side, some of the things that I'm, interested in, I have a few research focuses and themes is, one of those themes is on perioperative outcomes. So I do a lot of research on blood management, blood transfusions, how to minimize that around the time of surgery, how to improve patients' perioperative pain control with alternative medications and ice therapy and things like that. We're doing some randomized studies on different medications to use. So really, like I said, improving the patient experience around the time of surgery, trying to develop, develop and hone those rapid recovery protocols like I talked about. And then kind of the other thing that I'm, very interested and focused in is improving implant design and function. And so, creating a knee that feels a little bit more like a normal knee and is more stable with better implants, better, techniques and kind of going through that. And so we have a kind of a research team focused on that and what we call knee kinematics and improving how total knees move and how we can get them as close to possible as a normal knee, so patients can get back to really high level functioning with good outcomes.
Okay, great. Well, thank you very much. Now we're going to have a few minutes for any audience member questions. We're going to try and address as many questions as we can. So I'm just going to look through our Q&A here and see if we can get these answered for everyone. Okay, one question is, how long is the surgery on average? I guess discuss the difference, like how long a partial surgery is or a total knee replacement surgery is. Dr. Chalmers.
So both of those operations take around the same amount of time. I would say an average is an hour and a half to 2 hours. Sometimes it's more complex and could take a little bit longer. That's the actual surgical portion, of the procedure that I would be doing. Usually the patient's in the operating room for a little bit longer because the anesthesia needs time to, do the spinal and the other blocks and anesthesia that they're going to do. It takes time to set up the room and get everything set up. So typically patients in the operating room for 2 to 3 hours, I would say.
2 to 3 hours. Okay, great. Next question is, do we ever do double knee replacements here at HSS?
So we do a lot of knee replacements, what we call simultaneous bilateral knee replacements or bilateral knee replacements. Doing both at the same time and the same day. And patients that are good candidates for that are patients that have both knees that are equally painful and arthritic and that are both really affecting their function and quality of life. There is a slightly higher risk of blood transfusions, blood clots, and medical, and anesthetic issues around the time of surgery because it is a bigger operation and more stress to your body. So typically we have, restrictions on medically, age-wise and other medical factors that go into that. If you've had a blood clot before, if you've had a heart attack before, if you have diabetes or other medical issues that may make it more risky for you, ultimately, the patient safety and patient doing well medically and from an anesthesia standpoint is the most important thing around the time of surgery. So those are kind of the key factors that we consider in deciding, whether a patient is right for a bilateral total knee replacement. The other thing I tell patients and counsel, and Matt can probably speak to this as well, is it is a tougher recovery. It's basically twice what you had, and the benefit is it's only one recovery. You only have to go through it one time, but you're working with 2 knees instead of 1, and you're on a walker for longer, on a cane for longer. It takes longer to get the strength and everything back, so it's a bigger recovery.
Yeah, and when it goes really well with bilateral knee replacement, it's similar to a single knee replacement. I think the challenge is the fact that you really can't offload one knee. So you're going to put stress through both knees. So really load management early to make sure you're not increasing swelling is critical with a bilateral replacement.
Okay, great. What criteria is used to determine when a patient is able to leave the hospital post-surgery?
Good question. So basically, all the labs and vitals and everything have to be normal. Blood pressure, everything has to be, look good as far as your blood counts and your electrolytes and vitals and everything. That's obviously priority number 1. Your health and safety. Number 2, we want your pain to be adequately controlled. We don't want to have you go home and not, and have severe pain where you have to come back to the hospital. That's pretty rare that holds people up. And then number 3 is we want you to be safe on your feet. So every patient that has surgery at HSS has to be cleared by our therapists before going home. So you have to pass the milestones that you need. If you have stairs at your house, you got to be, doing some stairs before going. You got to be up and walking around fairly independently with a walker or cane or crutches. So you have to clear therapy, pain's well controlled, and all the medical and vitals and blood pressure and everything has to be all checked out before you can go.
Okay, great. Another question here is people who have tried steroid injections or gel injections, have you seen them face more issues down the line when they're ready to proceed with a knee replacement?
No, we don't recommend doing a steroid or gel injection within 3 months of surgery because there's some good data. There's some data from this institution that it can increase your risk of an infection after the surgery. Infection very rare at our hospital. It's about 1 in 500 patients, or about 0.2%. I think we have the lowest infection rate in the country, but it can slightly increase your risk. So obviously that's something to counsel patients. If you're going to have an injection, it means you should hold off on surgery for at least 2 or 3 months after. The only, I don't think it's a major negative to try or anything like that. I'd say the only, downside is if you try it for so long and then you wait until you wait too long to have the surgery, and then you're completely debilitated, and then you can't even walk hardly even a block, and then patients, like we had talked about earlier, the better shape you're in and the stronger the muscles are, the easier it is to recover after surgery. So it's just a harder recovery if you're very immobile prior to the operation.
Okay, great. Another question is that I was running before. Will I ever be able to run again?
Yeah, so that's a good question, and we have a lot of patients that ask that. There are kind of two philosophies on that. One, a lot of, traditionally, like I said, one of the biggest improvements in knee replacement surgery has been the plastic, and the plastic used to wear out. And so we used to tell patients you can't run or do anything. We used to tell young patients they can't have surgery because your knee's going to wear out. The likelihood of that happening with modern implants is very, very low. So I tell patients, and some surgeons still tell patients they should not or can't run. I tell patients you can do pretty much anything you want to as long as it feels comfortable and you're comfortable doing it. It's not a great activity, and I don't recommend it for any of your joints. Like Matt said, low impact activities overall are much better for all of your joints in your back. But if that's what you're passionate about and you can do it comfortably, I'm fine if you do that. However, most patients after knee replacement surgery, or I would say the majority, don't feel comfortable running after surgery, especially for multiple miles. A mile or two, patients can frequently get back to. I think the main difference is it's a metal and plastic implant and not cushioned cartilage and cushioned meniscus like your normal perfect knee is. And so it just is a different feel and a little bit more impact and kind of stiff and a different feel trying to get back to long distance running after surgery. I don't know if you have any thoughts or
Yeah, I've had
Matt.
patients return to running, but at shorter distances. I think the one concern is the knee may hold up, but are we actually putting more force into the hip or the ankle or the contralateral side? So we do see changes in motor control preoperatively. So if I'm getting up from a chair, I might, my right knee is bothering me. I might be shifting my weight to the left. And then after surgery, that pattern may still persist. So, it's important that you regain symmetry, you regain strength, and really, people who want to return to running, were you running before surgery or were you running 10 years ago? It might not be the greatest activity if this is something you were doing 10 years ago. So I think being realistic with your goals and expectations is really important. And other lower impact activities to get your heart rate up might be better suited for some people. But if other individuals are able to run, I think it's doable at lower distances. There's just not a lot of research across the rehab data on this.
And I think most of us would probably say that if you're able to run comfortably for distances, you probably don't need a knee replacement. Because if you're that high functioning, the likelihood that a knee replacement would make you significantly better is probably low.
Okay, great. Well, thank you. That's all the time that we have for today. I want to thank everyone for joining us. I hope we got to answer as many questions as we could. If you have any further questions, please email us. The email is provided in the chat. And I would like to thank our guests, Matt and Dr. Chalmers. Thank you for all of your information. And that's all for today. Have a great rest of your day, everyone.
Thanks a lot. Have a good one.
Thank you.